Sagarmoy, please.
Good afternoon, everyone. Thank you, Dr. Gitamani. And I thank the AIOC Scientific Committee for giving me this opportunity. My presentation topic is changes in the ophthalmic theatre in the post-COVID era. So in this era of COVID-19, we healthcare professionals are faced with the challenge of minimizing the risk of viral transmission to us. Ophthalmologists, as we are, we rely on close patient contact to examine the ocular diseases resulting in the exposure of the nasopharynx due to the dispersion of the viral droplets. Now, this is of particular concern when the patient time is prolonged, such as when we are performing surgery, we are getting exposed to the patient for a longer time, and that is actually a concern. Now, as we all know, the most common modes of acquiring the COVID infection are, number one is inhaling the aerosols that is generated during speaking, coughing, or sneezing by an infected person. Next is the fomites or from the surfaces. When a person gets infected, if he touches the surface and then touches his nose, mouth, or eyes. Now, both these modes of transmission can be prevented by simple 3 steps like sanitization to be done frequently, wearing the mask always, and maintaining a safe distance between each individual. Now, the concern that we have as ophthalmologists are, number one is that we all know that viral load in the conjunctiva and tears have thought to be low, but the viral load in the vitreous and the potential transmission of the virus was still now known, not very widely known. So this concern was mainly during the first phase of COVID pandemic that had come last year. So we also know that the risk of aerosol transmission of infection in the operation rooms has been well described. Surgical procedures like phacoemulsification and pars plana vitrectomy, which are high-speed machines, are considered to be aerosol generating procedures. Now that gave a concern to all the surgical ophthalmologists. So whether from these aerosols, one can get an infection from an infected patient. So apart from the safety measures that we have to take, apart from the normal measures, the COVID, from the advent of the COVID pandemic, few important things we have introduced, like all patients at the entry, all the patients and the attendants are screened for the temperature and SpO2 level. We take a history of travel, whether any fever or cough the patient has been suffering from is elicited. Then the patient is provided, patient and the attendant are provided with hand sanitizers. Wearing of a face mask is compulsory. If suppose the patient has not come with one, we try to provide, and then only we let the patient enter along with the attendant to the hospital. And as much as possible, only one attendant is allowed, except in case of kids and old patients who might need more help. Also, we prefer visit by prior appointments. The doctors and the staffs in the hospital are to wear personal protective equipments. We ensure that regular sanitization and disinfection of the surfaces are done throughout the day of the whole hospital. Strict hand hygiene protocols are followed, and social distancing is practiced with alternate sitting arrangement in the waiting area. Now you can see here a few of the pictures which show that we have the temperature thermometer, the sanitizer, and the pulse oximeter. Then the reception area where we are maintaining the distance, the waiting area where alternate sitting arrangement has been made, and all the optometrists and all are wearing the PPE kits and then examining the patients. Even we can place a shield in the chamber where we sit, so that the patients, when they cough or talk, the aerosol is not generated to us. And also we maintain a safe distance when the patient or the attendant sits from us. Regular sanitization is carried on, and these all have to be monitored very carefully so that each and every step is being followed. Subsequently, in the OT, that was when the patient had entered our hospital. Subsequently, when the patients are posted for surgery, many different techniques have been followed. Like you can see here, the draping part, the patient as well as the even the microscope has been included in the draping, and the draping is so much so that the aerosol generation could have been stopped. So these were all during the first phase when we were very much concerned and we didn't know how the COVID would behave. You can see here the operation surgery is going on and the assistant as well as the surgeon is wearing the PPE kit and operating. We can see one more picture here where the surgeon is also wearing a face shield. I don't know how he might have been looking through the microscope. Maybe he is doing a surgery where the microscope was not needed. But all these had pushed us into such a cumbersome situation where we need to do surgeries, but we need to protect ourselves as well. So coming to the investigation part, routine pre-op investigations were to be carried out along with special precautions during biometry, B-scan or syringing. Also, we ensured in all our surgical patients, if those were elective, we ensured a negative RT-PCR test. And if any emergency surgeries have to be posted, we at least do the rapid antigen test and subsequently wait for the RT-PCR report. Inside the operation theater, the operation theaters are equipped with AHU, which ensures that it is safe from microorganisms. Only one patient is operated at a time. Patients' eyes are cleaned with betadine before surgery. Although these are routine procedures, but still we are more careful during at this era. Every patient is provided with a disposable cap, mask, and foot cover before surgery, and surgeries are performed under topical anesthesia as far as possible. Also, disposable single instruments are used as far as possible. Trolley sheets are changed after every surgery. New sheets and drapes are used for each patient. And after every case, the OR is cleaned thoroughly. So these we have been earlier also, we have been following up before this era, but during this, we should be more careful and it should not be missed at all. So when talking about the last year, when the first phase of COVID had come, so there were many operation guidelines which were released. Also, the AIOS had released some guidelines. So some of these guidelines we had followed during that time, but subsequently with more research, we found that the aerosol generation through phacoemulsification or from the vitrectomy, those are very less. Those were not less than 10 microns in size. And so it actually doesn't pose a risk to the surgeon if the surgeons and the operative staff, they maintain proper other COVID protocols like wearing face masks and other things properly. So you can see I'm back to the original form. This time in the previous year, I tried to operate with the PPEs and all, which was so cumbersome. And subsequently, when the researchers showed that it is not that dangerous if we can take proper precautions. So I'm back to my original form of surgery. Now to conclude, are we really dealing with the post-COVID era? Because the COVID, I think we have to live with the COVID, we have to coexist with the COVID. So it is not actually a post-COVID era that we have to live and we have to follow these protocols always. And it should be a new normal for us. And second factor is we are trying to include RT-PCR or rapid antigen tests into our routine preoperative investigations until further research shows that it's not needed. And we should consider every patient who enters the hospital as a potential COVID patient. And because every patient, we should also consider as a potential surgical patient. So we should follow all the safety protocols that have been advocated for COVID. And also we should ensure the vaccination of all the hospital staffs and doctors, and if possible, motivate all the attending patients so that we can all fight the COVID and coexist with the COVID and carry on our duties as ophthalmologists. Thank you.